Again, a fracture, not as exciting as the arthroscopies, I suppose, but more challenging. I find this more challenging than the routine arthroscopies. So, 21-year-old polytrauma medical student hit by a truck when going home on a bike, taken to a local hospital, which is their own hospital. He was resuscitated there and shifted to our hospital. Next slide. So, trauma team alerted, as we do. On arrival, conscious, coherent, communicating, so ABCs, right? Saturations were slightly low, but improved with oxygen. Hypotension, tachycardia stabilized. Okay, that's his initial chest X-ray. And that's the trauma series. It's not projecting correctly, but has a vertical shear of the pelvis, has a fracture of the proximal humerus, which is not very well seen. The head is superior and posterior dislocated, and the tuberosities are not seen. Next. So what would you do?
Somehow the X-ray did not come out very well. Could you describe the injury?
It's basically a fracture dislocation of the shoulder on the X-ray, and a scapular fracture too. Tuberosity, sleeve avulsion. Put it that way. The CTs will come next, so you will see that. No, not proximal. Well, it is part of the proximal humerus, right?
I think before we go to this question, we need to have more information because
Yes.
the injury pattern is not clear as of now.
Okay, now go to the next slide. You'll get to see. Next slide. No, there is no need.
The next present.
I said further imaging, what monitoring and plan for surgery is. That's what I was asking for actually. Would you go for shoulder fixation or a pelvic fixation first? You will see that very clearly in the images. There are images following. Okay, we'll go to the next one. There is no looking for. So that's his CT. So what I was trying to get at is look at the patient as a whole, not just the shoulder. This is what needs addressing more urgently. Okay, next. As you see, he has a pneumothorax, so chest drain put in, and that's the amount of damage on the shoulder. That's the pelvic injury. So that's the shoulder images. The key images are those ones.
Let's focus
the
on
pelvis
the shoulder.
and this one.
Can we come back? The previous slide. Okay. So let's just focus on the shoulder.
Yeah.
Otherwise, discussion would be very lengthy. For everyone's attention, that if we spell out what are the injuries here.
Wait,
so I can see a GT that is not there on the humerus, and there is.
So if I just try and point out the lesions, sir. One is the tuberosity avulsion, the GT and the LT. Second is the posterior shoulder dislocation, and third is a scapular fracture.
Yes.
I could see these three injuries in these scans, if I'm correct, sir.
Correct. So that's what was done first, because when you had to position for your shoulder, wanted to get this pelvic shoulder stabilized. Fracture 2, which was undisplaced. When you get these reformatted images, just don't go in. You have to actually analyze this better. See, this fragment is not at all seen on the reformatted. The person who reformatted it took it off. So I went down, did it myself. Unless you do that, you will not know exact extent of the injury.
What made you think that you need to go back down?
Sorry?
What made you think that you are missing that fragment?
That one. That's why 3D images are not as important as your 2D images. No, not only that, each image you study, you look at the fragments. If some of them are missing on your 3D, go back to your 2D. 2Ds are more important than 3D.
So he was not finding the GT.
So when I reformatted it...
He was looking for it. He was looking for the GT.
Yes.
And he couldn't find
And you reformatted it, you see the GT and the LT are exactly where they are supposed to be in the last image there. Here. And they are aligned at the joint, but the whole humerus is off.
There is a lot of lateral displacement of the humerus.
Superior and posterior.
I've seen one patient, and I just failed to understand why. There's a lot of hematoma in.
Yes, there was a big hematoma, a lot of laceration. You can see that arm which was shown, it was completely shown. Yes. Rib fractures, pneumothorax. Yes. Posterior superior escape of the humeral head. So even that has recovered after the tube was put in.
So he's how many days post-trauma now when we are
This is
discussing?
1 week post-trauma. Because second
The decision-making.
anterior part exposed completely. So then you could expose the humerus first, because if the humeral head is sitting back, your approach to your scapula will also be difficult. So once you get the humerus back where it belongs, then you can work on the scapula. So did the beach chair and then did the deltopectoral, and I think those questions are hiding behind those images. But basically, I wanted to go either for the Jude approach or from the window approach. But with the Jude approach, there was so much.
Modified Jude.
Yeah, this is modified Jude, but regular Jude, the most of the muscle is damaged.
Yeah.
So you're not going to get much of the elevation like you would
And
get
most
with a
of
normal
your problem
Jude.
is on the lateral side.
Lateral
you don't need
side.
to
So
worry
you
about
fix the spine and the.
it. I am intrigued. I mean, nothing wrong in taking a long incision, but that's too long incision for a sleeve avulsion.
It is too long an incision, but I wanted to be having a good exposure before I struggle in there. And the smaller, only the top part was mostly used. So that's what it is. And implants, what would you use to fix the sleeve avulsion?
So anything, whatever pleases you, because there are so many options. Or even a transosseous suturing works very well for, since you're doing open, it doesn't matter whether you do anchors or transosseous suturing, they will come well. You just have to put them in all a sequence to ensure everything sits in there.
So first reduce the fragments, first reduce the head back in.
Moment the head is reduced, the cap just sits on the
Cap
head.
just sits on top, but getting that cap again correctly sitting is also was tricky, in the sense getting that alignment right. So first reduction, K-wires, then a screw, and then you put the sutures through this and the intraosseous sutures.
What did you do to the biceps?
Biceps, I did a tenodesis to the pec major. So the scapula again, it's a straightforward fixation. I did not do the acromion on that one. So.
Can we have the X-ray? Post-op. Next.
The biggest problem was that, the last part, because all the muscle is damaged, both on the muscular side and on the tuberosity side. So it's a bipolar region of the muscle. So I wasn't sure how much this is going to improve. And there's a lot of neurological injury probably because of the crush itself. So I used the screw system and...
See the video?
See, I think there is an element of neuropraxia on the axillary nerve because of the crush itself. That's probably recovering now. Now when I checked him just last month, his anterior deltoid, middle deltoid, posterior deltoid, all of them are working very well. Means... The philosophy plate doesn't do anything for GT. No, the philosophy plate will never stop a GT avulsion. Yes, the sutures are put intraosseous with a screw too. So there is a double fixation for that. What the suture does is actually compresses the tuberosities down because you're using an intraosseous suture, and the screw is only a rib stop for the tuberosities. So the intraosseous suture is the more important part. Sometimes you overcompress these because there is an element of crush on the metaphysis.
Thank you.
Scapula, if you look at the glenoid itself, was facing downwards. And it was, yes, the glenopolar angle, and it was rotated. If you look at the initial images, it was completely rotated. And an angulation of about 45 degrees. No, even the spine is broken, no? Spine is broken, acromion is also broken. No, there is a fracture on the acromion too. There is a fracture here, see that?
Hello, sir. As far as scapular fracture is concerned, whatever approach you are doing, like Judate or modified Judate, patient always end up in having a scapular dyskinesia and some sort of wasting. So, what I think, the lateral pillar is the most important part of a scapular fracture. If you do by a minimally invasive approach, that is very well by a Peter Cole minimally invasive approach between an infraspinatus and a teres minor, and you can place a plate, a recon plate on a lateral player. I found most of the patient with full functional outcome, with full like range of movement, and whatever whenever I have done a Judate or modified Judate, there is some sort of scapular dyskinesia and wasting, and there is a limitation of range of movement exercise. I think the most important is the lateral pillar, and this is the only part we found a good bone stock or bone quality in the scapular bone.
I'm not sure I agree with that. The
too.
scapular dyskinesia is not related to the approach or the exposure.
Yeah.
These are complex fractures. I would never do it through minimally invasive. I would need the full, either the Jude or the modified Jude, because it's not easy. It's what he has done and achieved that is not easy. And especially putting those implants, there's very little space. And plus with the underlying lung contused and the pneumothorax, you have to be extremely careful. So all the screws that you get are only 10, 12 mm. Yes. You do 2 passes, there is no hold. So your first pass is very important. The only modification can be, you can put the plate on the lateral pillar, which is the strongest bone. That's the only one available there.
I normally use a pelvic set for doing this, but your scapular dyskinesia should not happen because of your approach. Because the scapula is stabilized by muscles more medial to the scapular, medial border, and superiorly. These approaches are not disturbing any of those. It is the fracture which damages the medial border of the scapula which causes the scapular dyskinesia, not your approach.
I would like to make a comment. I mean, and I agree with Ashish. These are very difficult fractures. Once I was there for 5 hours. I put the screw from the inferior with a modified plate, buttressing the inferior glenoid, and I put a screw. It didn't hold. I spent 5 hours getting it. I left it. I had to leave and come out because the screw is not holding in any direction, going up to the coracoid as well. So easier said than done. Scapular fractures can be a nightmare. The second case I had, I was doing an arthroscopic fixation. Ashish, you do that superior screw. The trajectory was not coming right. It was a 2-part fracture of the glenoid. And eventually, when the screw again didn't hold into the inferior fragment, getting everything right, had to leave it. So easier said than done. I agree with Arun. Just the lateral pillar, putting a plate lateral pillar, and I don't know whether you actually need it or not, it's just the lateral pillar and not involving the glenoid.
So I think we need to wrap up this case.